Good evening, Kartikeya. Good evening, Lakshman. Can you guys hear me? Can you guys see me? A very good evening, one and all. If you can hear me and see me, just say a hi or a hello. Good evening, Neha. Good evening, Aisha. Okay, let's start. How are you? How is the mood? All good? So the week should have started well. Dr. Mamta must have taken the basics of bacteriology yesterday, and I am here back with continue with the same pathology, right? So are you guys okay with starting with a little bit of some random questions from the previous class? The last Nishchay batch we did talk about reversible, irreversible cell injury and necrosis, right? Are you guys ready? If you're ready, let's fire some questions. Vanakkam Lakshman. Good evening, Roy. Good evening, Swai. And thoda धीरे धीरे बढ़ाओ. It's fine, Swai. It's okay. Okay, let's start. Fine. So let's start. Few random questions. I want you guys to answer whatever comes to your mind. Okay. Tell me, what is the first thing which comes to your mind when you think of a cell injury as an etiology? Is it like hypoxia, physical, thermal, chemical? What is the first thing which comes to your mind? Good evening, everyone. Hello, Lalit. Perfect. It's hypoxia, right? What's the most common ion which is seen or accumulates in case of an reversible cell damage? Reversible cell damage. Sodium, potassium, calcium, magnesium. Few options. Great, it is sodium. Same, irreversible cell damage. In reversible cell injury, the ion which accumulates is sodium, and in the irreversible cell injury, the ion which accumulates is calcium, right? Perfect. Nice, Suniksha. Okay, only for few classes. Okay, perfect, great. Okay, next question. We read about two findings: myelin figures and amorphous densities of mitochondria. Both of these findings are seen in reversible cell injury or irreversible cell injury, or both. Reversible, irreversible, or both. Sure, Lalit. And we have raised the thing in the tech team. We are just looking at. And if it's possible, can you just ping me your phone number in my Instagram or Telegram? It is seen in both. Great, amazing, perfect. Next question. In case of necrosis in microscopy, you will see pink color, blue color, or both. What will be seen in the microscopy of necrosis? You will see only pink color, right? Perfect. Okay, great. Sunakshi Sharma, मेरा हिंदी is not so good, so इसलिए मैं अंग्रेजी से बोल सकता हूँ, ठीक है? Okay, perfect. Okay, next question. We have read about myelin figures again. So what do you think myelin figures is composed of? Is it protein? Is it calcium? What it is? What is myelin figures composed of? सोनाक्षी, आपका प्रॉब्लम क्या है और डाउट क्या है, आप हिंदी से पूछो, मैं अंग्रेजी से रिप्लाई कर दूंगा, ठीक है? My Hindi is not so fluent, that's why, Sonakshi, fine? It's lipids, right? Phospholipids primarily, right? Amazing, great. So your things are set. We have set the premise on what it is made of and what, just quick revision, right? So we'll try to do this every time before every class, a quick revision of whatever we learned in the previous class, right? If you've not read the previous class, it's completely fine. Still, you can recollect few things, right? That gives us the confidence to go to today's class, right? In today's class, I'll be completing these two things in your CBME curriculum, which converts the completion of cell injury and also necrosis and apoptosis. If you look carefully at the CBME curriculum, they have not included necroptosis and pyroptosis in the curriculum, but it is there in the recorded lecture, and also I'll cover a little bit here as well, right? There are few topics which are there in Robbins, which has come in an exam, has not been covered in your curriculum. I'll try to cover them as well. They might not come in a university exam, but for an understanding purpose and for a next exam, NEET exam purpose, it might be useful, fine? So this is what we ended with last time, the different types of necrosis. We have 5 different types of necrosis: coagulative, liquefactive, caseous, fibrinoid, and fat. These are the 5 different types of necrosis. One statement: all these necrosis, what will be the microscopic color? Whatever be the necrosis, microscopy, like you guys said, it will be pink in color. It will not change. By default, whatever the type of necrosis, microscopy will definitely be pink in color, right? Generally, what happens is, when you go to the exam point of view, they might ask you which is most common. Remember, most of the time, not all, most of the time, the first heading or first subheading becomes most common. By default, coagulative necrosis is the most common type of necrosis. This is a clue. This is just a trick. It's not always. Most of the time, the first thing would be the most common, right? Now, with that in mind, let's go and see what is coagulative necrosis, what is liquefactive necrosis. Okay, Lakshman, gangrene will come under coagulative necrosis. Just few minutes, we'll definitely take care of that. Okay, perfect. Okay, gangrene is a gross terminology. It's not a microscopic terminology. I'll cover that for sure. Fine. So now let's have a quick look at difference between coagulative necrosis and liquefactive necrosis. Right? If they have covered that in your class, can anyone tell me where do you see coagulative necrosis? Where do you see coagulative necrosis? Dranix, RRR, I'll go slowly. This is for Nishchay Batch. We'll be covering the topics a bit faster. Okay. You will see in fact of any solid organ, right? So any solid organ, in fact, I call as in coagulative necrosis, except CNS or perfect except brain, right? Perfect, amazing, right? Now, Lakshman had put a question that gangrene is also a type of necrosis. Gangrene is a term given for anything greenish black in color in naked eye, right? So gangrene here, we have two types of gangrene. One is dry gangrene. Dry gangrene comes under coagulative necrosis only. So let's say I don't have any blood supply to my finger. What color it will change to? Great, and I'll take care of that. What color do you think it will change to? It will change to black color, right? You must have tied your rubber band. You must have experienced that. Keep the rubber band for 10 days. Entire thing will become black in color. If something becomes black in color to the naked eye, I call it gangrene. So can I say finger is a solid organ? Definitely. So in microscopy of the gangrene also, I'll have coagulative necrosis only, right? So if the question comes on gangrenous necrosis, or if the question or viva is asked on gangrenous necrosis, tell that gangrene is a gross terminology, but microscopy is undoubtedly your coagulative necrosis. Is my voice fine? Is it only for Sai Rupa? Can you guys just comment on that once? I'll increase the sound a little bit. If the voice is slow, I'll try to increase it. Fine. Okay, great, guys. Sai Rupa, just can you increase the volume locally? If it's fine, let's go ahead. Fine. So that's the difference between gangrene. Now let's go to liquefactive necrosis. Everyone here said that except brain, right? They did teach you in your college also, every organ except brain will have liquefactive necrosis, right? We'll try that. Except brain or CNS, right? Okay. When they taught you this in the class, how many of you asked your teacher or lecturer back why? How many of you asked it why? Did you guys ask why, or you just accepted the fact? If you have accepted the fact, there's something which I want you to learn here. Never ever accept any fact. You are going to ask why for each and everything. That will give us lots of unexplored things, right? So please do ask why. Sometimes you will get an answer. Sometimes you won't get the answer. If you don't get the answer, go and read. That's what makes us much better, right? Perfect. Great, Pari. Okay. Now let's understand why my brain is having a different type of necrosis and why other organs are having different types of necrosis, right? So when you look at coagulative necrosis, the main mechanism of action is protein degradation. Okay, protein degradation is the main mechanism of action in case of a coagulative necrosis, right? Let's have that and let's understand it. Fine. Medical basic knowledge, Hindi language thoda problem hai. So you ask me what is the problem, I'll definitely try to explain it. Okay. So now, have you touched your brain in first year? Cadaver? That's something which is exciting, right? Once you open the skull with all the mallet and hammer, you open up, you must have touched the brain, right? The brain is soft, firm or hard? Brain is very soft, right? It's very soft, right? So in other words, touch your belly, touch your tummy. Tummy is also soft. I'm sure most of you might have not gotten tummy. Wait for 30 years, genetics of India will kick in and obviously you'll get in tummy, right? So tummy is also very soft because tummy as well as brain has the same substance, which is fat. If fat is there, automatically it'll be soft, right? So the entire brain parenchyma is made of fat, rich in fat. Now tell me, if I have a necrosis where the main mechanism is protein degradation, can it destroy brain? Hello, Faizan. Can it destroy brain? It cannot destroy brain, right? So I have fat in brain. So what do I need? Protein degradation or lipid degradation? What do I want? I want lipid degradation, right? Only when I destroy lipid or fat, then my brain can easily be destroyed, right? So in other words, the main mechanism of action of liquefactive necrosis is lipid degradation, right? Or in other words, enzyme activation. So enzyme activation is the main mechanism of destruction in case of an liquefactive necrosis. So example, I need an enzyme lipase. Since you're talking about brain, I'm taking the term lipase here, fine. So this lipase can come from two places, right? One, it can come from the cell itself. Tell me which cell organelle will have lipase. There's a cell organelle inside my body which has lipase. Definitely brain. Give me a second, I'll definitely do it. Which cell organelle will have lipase? I'll do gangrene. I've not completed it. Once we complete it, let's talk about gangrene more, right? It's lysosome, cell organelle, right? So one, it can come from the cell. We call the process autolysis. When the cell dies, lysosome also dies and all the enzymes come outside that can destroy the brain parenchyma, right? Autolysis from lysosome. That's one. Or can I say it can come from WBC? Will necrosis have inflammation? Necrosis by default will have inflammation, right? When it comes from WBC, I use term hetero. Hetero means different lysis. I'm having the lysosome coming from a different cell apart from the brain cell. We call it heterolysis, right? But the premise is I should have enzyme activation or lipase activation, right? That is the one. But I don't want you to remember it. I am 100% sure you will never forget it. The reason why telling with confidence you don't want to remember brain infarct is, tell me, if a patient has stroke, that is brain infarct, right? Will any doctor go and take a brain biopsy? Honestly, no, right? Honestly, no, right? They won't. So which means practicality of this point is not required, okay? It's not required. No one is going to take a brain biopsy. If someone asks to take a brain biopsy, the doctor should have a brain biopsy first, right? So I don't want you to remember this in real life. I'm not going to apply this at any point of time in my life, right? Chaitanya will definitely take care of it after some time. We'll finish the lecture, ping me later, I'll definitely help you out, fine? Now, where else I can apply? I need to apply. If I don't apply, it's a waste fact. You need to apply by default, right? Now you guys know for a fact, there is one organ in my body which can secrete lipase. Which organ is that? Which is in the GIT, which opens into the ampulla of Vater, which has two ducts, named ducts. Pancreas, right? So I have a condition called as an acute pancreatitis. In case of an acute pancreatitis, what happens is the entire pancreas will get activated, which means the trypsin becomes trypsinogen becomes trypsin, chymotrypsinogen becomes chymotrypsin, fine? Faizan, only I have a problem with Hindi, others will talk, but still you can ask me a question, I'll definitely answer that, fine? Okay, so these things will have an issue, right? So when pancreas is getting auto activation, can I say pancreas also has lipase? Good evening, Mitanshu. They do, right? Lipase activation, again enzyme activation, that is the premise. So acute pancreatitis, you will have definitely liquefactive necrosis, right? Next, so I told that I have both. Neha, brain biopsy is not required. We do a CT or an MRI to identify every brain lesion, right? When brain is dead, I'll have symptoms. We don't take a brain biopsy. It's not very easy to take a brain biopsy, fine? Okay. Next, I told you that one of the way of destruction is WBC, right? Okay. So when I have excess of WBC in some random thing, okay, I'll come to it a bit. Very good question. When I have excess of WBC in some random disease, can it have excess of lytic enzymes? Yes. Tarini, I will answer your question also, fat necrosis also very soon. We'll read about fat necrosis when we come to fat necrosis. Right? Hello, Rahul. Definitely, right? So you'll have lots and lots of it, right? So not leukemia, not exactly leukemia, because leukemia is abnormal WBCs. I'm talking about normal WBCs. When you have a tiny injury, have you ever seen pus? Pus coming out of any injury, patients or yourself? Pus is nothing but collection of neutrophils, right? When I have an acute infection, very acute infection, suppurative infection, pus forming infection, I will have that. In other words, have you heard the term abscess formation? Abscess formation is nothing but a collection of WBCs. You'll have extremely high amounts of WBCs or pus inside a closed space. There also I'll have liquefactive necrosis, right? Now, someone asked me question of what is dry gangrene and wet gangrene? The difference between dry and wet gangrene is simple coagulative necrosis where I am not having any blood supply. I'm just asking you a simple question. If I don't have blood supply to a tissue, let's assume my finger, can bacteria and lots of pus form in the place? It's slowly dying. Slowly defense mechanism is going. Can it get infected? It can get infected, right? A carrot, when you keep outside for 10 days, it gets infected. My finger also will get infected, right? So that time, when it's getting infected and when there's lots of pus oozing out, they use the term wet gangrene, right? Wet gangrene is nothing but infected dry gangrene. That's all, right? So wet gangrene also will have your liquefactive necrosis, right? Wet gangrene is nothing but gangrene with suppuration. Suppuration means there's pus formation. When I have lots and lots of pus formation, it is, right? So that's why wet gangrene will have liquefactive necrosis, and dry gangrene is just no pus formation, no suppuration, simple coagulative necrosis. Clear, guys? Whoever asked the question? Okay. Okay. Abscess and ascites. Tanmay, ascites is a disease where I have lots of fluid collection inside the abdomen. Abscess is any place when you have pus. That's the difference, fine? Gas gangrene, it's an infection by Clostridium. You will read them when you go to microbiology. Okay. Tanmay, wet gangrene can happen in any organ when there is a superadded infection. That's what it can happen, right? Okay. In dry, I will have infection. I won't have suppuration. Suppuration means any disease when there's lots and lots of pus formation. I use the term suppuration. Okay. Clear? Your doubts are clear? Which one you're not able to understand? Tell me. I'll definitely answer your question. It's okay. Fine. Perfect. So that's the difference between dry gangrene and wet gangrene, right? Someone asked me, yes, pancreas is a solid organ, Abir, but what happens is the mechanism changes. Ischemia of a solid organ will cause coagulative necrosis. Acute pancreatitis is not an ischemia, right, Abir? It's an inflammation. That will cause liquefactive necrosis. That's the difference here. No, Lakshman. Gangrene means loss of blood supply. If the gangrene has gangrene plus pus formation, I call it a wet gangrene. Only pure gangrene, no pus formation, I call it a dry gangrene. That's the difference between dry and wet gangrene. Clear? Okay, Neha, I'll ask you a simple question for everyone. This is a question. Right? So when you have an infection, let's say I'm cut, I have my finger cut. Can there be just an infection and no pus formation? Yes. Pus formation means when I have too many infections and too many neutrophils, it's an superadded infection. That can result in pus. I can have an infection with pus, without pus, right? So when I have too much pus in a dying or dead tissue, I call it a wet gangrene. That's all, fine. Pus in an enclosed space, I call it an abscess, fine. Okay, Tendulkar. So dry gangrene and wet gangrene is very simple. Let's go to that. We'll come back to the rest of it later, right? So let's assume gangrene. So gangrene is nothing but is a gross term given for an black discolored tissue which has lost its supply. Okay, this is how it is. Fine. I'll ask you step-by-step questions. I want you guys to answer it. Fine. Yes, Abir, you are right. Okay, so now there is a complete finger which has lost its blood supply and it's become black in color. Will the patient come to a doctor? Yes, Pari, they will, right? So the patient came to me. I saw the dry gangrene. The patient visited a doctor. We remove the finger. We amputate the finger. That's a treatment. Amputation means removal of the finger, and I treat. So when they come to me immediately, is there a chance of infection or suppression becoming less? Thank you, sir. Definitely, right? Let's assume the patient has not come to a doctor. The patient is a very remote place, not accessible to a doctor, right? So when they're not accessible doctor, can I say more and more and more infection will grow on the dead tissue? It's a dead tissue. Any tissue you keep outside, will it decay? It will decay, infection will come by default because all these materials, bacteria will come and try to eat it. Fungus will come and try to eat it, right? So now when it's having an infection, superadded infection with flowing pus formation, I call this a wet gangrene. So wet gangrene is nothing but a gangrene with superadded infection and with lots and lots of bacteria and lots of pus is what is called as a wet gangrene. Dry gangrene is nothing but just a dead tissue. It's dry and dead, no pus. Pus is a liquid, right? Pus is just a liquid. So when it has liquid, that is how it is. When you don't have a liquid, it's dry. That's all. Fine. Okay. Poco, let's listen. Let's ignore. Sonakshi, if you still really have a concern in understanding, do let me know. I'll try to simplify it for you. Fine. Okay. Every necrosis will have pain, Lakshman, right? Kumar Priyanshu, gangrene means loss of blood supply. I gave cut as an example, that's all. Anywhere I have suprarenal infection, I call it a wet gangrene. Fine. Let's move out of gangrene. If there's any doubt, do let me know. Okay, let's go up. Right. So we know about liquefactive, we know about coagulative necrosis, right? Now, microscopy of liquefactive versus coagulative necrosis, there's a major change. In coagulative necrosis, we have something called an architecture being maintained, and in liquefactive necrosis, architecture is being lost. There's a major change. We'll see what it is based on the few examples. Fine. Okay. So now, when you have architecture being maintained, there's one more name given for it. Ghost cells are being present here, and there are no ghost cells here. When I don't have ghost cells, I call it liquefactive. When I have ghost cells, we call it coagulative necrosis. Clear? Fine. Now, this is an image from Robbins. Okay, this is a gross image from Robbins. Let's mark few areas. Let's mark this as 1, and let's mark this as 2. Which you think is dead, 1 or 2? Simple questions. 2 is having a red color tinge, which means blood supply is there, right? White is, 1 is kind of white or pale or yellowish in color. 1 is dead area. This is called as an infarct grossly or a necrotic area grossly. Fine. There's a kidney cut surface where you can see the kind of the papillary structure here, where you have the necrotic part. This is how the necrotic part looks to naked eye. Fine. Perfect. 1 is dead, right? The same thing if I look into the microscopy. Let me look into the microscopy. This is also an image from Robbins. Can anyone tell me what structure is this? You might have seen this in your first year histology. I'm not sure if you remember that. That's a classical glomerulus. Okay. So that helps me to identify it's a kidney biopsy, right? I know it's a kidney biopsy. That's a glomerulus. Anonymous Farai will start soon. Don't worry. Okay. Now, if that is glomerulus, can anyone tell me what structure is this? What structure is this? Can I call this a tubule, which is very close to my glomerulus? I am not saying it's PCT or DCT. Let's call it a tubule. Is that a tubule? That is a tubule. Perfect. Fine. Now, a real test comes for us. Let's see if we have understood necrosis rightly or not. Which of this 2 tissue is dead? I'll zoom this. Which of these 2 tissues necrosed? Necrosis color is always pink. Tell me which is necrosed, glomerulus or tubules? Whatever it is, a loop of Henle also is fine. Which is dead? Tubule is dead? Definitely, because tubules don't have a blue color. Karyolysis has happened, only pink in color, tubules are dead. Perfect. Okay. Now tell me, honestly, if something is dead, I cannot identify what it is, right? But you guys told it is dead tubule. Why did you say it's a tubule? Because of the shape. That's what I meant by architecture being maintained. I can say it's a dead structure, what it is, even after it's dead. That's what it means by architecture being maintained. Clear? Perfect. So that's the reason for architecture being maintained, right? Now the ghost is just an analogy that came once in an exam. That's why I'm using the term. Ghost is nothing but Scooby-Doo, Casper, ghost. Outer shape will be there, no life. Same. Tubules has the shape, but no life inside. So we call them ghost cells, right? That's all. So perfect. This is a coagulative necrosis, right? This condition is an acute tubular necrosis. We'll read more about them when we come to kidney chapter or when you go to your medicine. This is how acute tubular necrosis looks like. Acute tubule is undergoing necrosis, acute tubular necrosis, right? Now, let's go to liquefactive necrosis, right? The premise of liquefactive necrosis was lipase activation, right? Have you seen your mom, dad, anyone at home melt butter and make ghee? Undoubtedly, it's common, Lakshman. Every organ, in fact, is coagulative. Coagulative has to be common. You must have, right? So when I destroy anything fat-rich, will it lose its architecture? Butter will not be butter. It will melt and form a liquid. That's the name I give as liquefactive necrosis. It's becoming a liquid. Once it becomes a liquid, we won't have it. Fine. Kumar, why should chronically it should undergo necrosis? Necrosis, loss of blood supply. I stop the blood supply, it's dead. That's all, right? Most of the necrosis are acute. Okay, perfect. Fine. So what happens, this is also image from Robbins, this entire thing is kind of dissolved, it will become liquefied. If something is liquefied, it will not retain the architecture, it will not retain the shape. That's why we say architecture is being lost in case of liquefactive necrosis, architecture is being maintained in case of coagulative necrosis. Clear with coagulative liquefactive? Okay. Gangrene is subtype where you have the differences. Fine. Those are the first two necrosis. Let's go to third necrosis. The third necrosis is caseous necrosis. Fine. Caseous means chalky white, white in color, right? Honestly, I'll teach you something which is right, and I'll also tell you that's not how most of the books are written. Honestly, caseous necrosis means chalky white in color. What will be the color in microscopy? Pink or blue? Can I say that even in necrosis you'll have inflammation? Those are inflammatory cells. Okay, the blue color in between the tubules are the inflammatory cells which comes inside. It will be pink in color, right? So can I say caseous necrosis is more of a gross terminology? They are a gross term. They are not a microscopic terminology, but you will see in multiple places in Robbins and in many other pathology book, microscopically there is caseous necrosis. It cannot be cheese-like in microscopy. It has to be in gross only, right? But most of the time we use the term microscopy caseous necrosis. Caseous necrosis, one thing which I want you to remember, one etiology, never forget TB. TB is an amazing disease, right? We'll learn about TB very soon when you go to inflammation. TB is such resilient organism, we cannot do anything to that. Whenever you see the term caseous necrosis, now or when you become 70 years old also, tuberculosis should be the answer. Be it India, abroad, anywhere, it's only 1% TB. If I rule out TB or if TB is not there in the option, then I can think of other findings. Histoplasmosis. This only when TB is ruled out. Or coccidiomycosis. Only when TB is ruled out, I can think of this. This is always the first diagnosis when I see a caseous necrosis. Fine. Yes, Punit, wherever you have TB, it will be almost always your caseous necrosis only. Fine. Because see, caseous is not a misleading term. Microscopy, I have pink color necrosis only. I won't see the chalky white or cheesy white color, right? That's why it's called as a caseous necrosis for gross. Even in Robbins, if you look at the image, this is caseous necrosis. It's white in color. It cannot be white color in a microscopy, right? It'll be red in pink in color only in microscopy. That's why I said microscopy, I don't have the term, but most of the books use them. Ignore that fact. Fine. Now, microscopy, what do I see is I do see a little bit of granularity. We'll see granularity in the necrotic area. That's what we call it an caseous necrosis, right? In addition to that, you'll have one more structure called as granulomas. Microscopy of almost every caseous necrosis, granulomas will be present. We will read about granuloma when we come to inflammation chapter. Fine. Tanmay, it depends on the organ, right? If the normal color of a bone or a cartilage is whitish and bluish, I won't call it. But generally, if it's an infarcted area, I would call the term necrotic. And also, it will become a little bit softer. I can use the term necrotic, right? What does granularity mean? Great question. So when I see a uniform pink color, little bit white areas, sand is granular. If you put sand on a table, it will not be uniform, right? You'll have lots of areas in between which are empty, right? That is granularity. Fine, Karthikeya. Kumar, why granuloma? How a granuloma is formed, we'll definitely learn when we go to inflammation chapter. As of now, we'll restrict to this. We'll have a big answer one day on granuloma. We'll know exactly how and why it happens and how it looks as well. Fine. So that's about caseous. In multiple places, it will be written caseating granulomas. The word necrotizing granulomas is much more comfortable than caseating granulomas. Fine. Let's go to the next. What are those pink spots between tubules? Which one? These ones, Kajal? These are RBCs. These are RBCs, the red ones, and in between the blue dots are neutrophils which can come as a response to your necrosis. Karthikeya, for an undergraduate, you will have a question on, question will give you history of tuberculosis. That's more than enough. That headache is for me, whether to identify granular or not granular. Fine. Okay, perfect. Let's go to the next. Okay, the next necrosis is fibrinoid necrosis. Right? Snehajit, there will be a finding called as granuloma, which will be seen most of the time with caseous necrosis because TB will form granuloma, right? Granuloma is a different finding, right? We will see how a granuloma is formed when we go to the inflammation chapter. That's where we will read about tuberculosis, fine? Okay, let's come to fibrinoid necrosis. That's the fourth type of necrosis, right? Oid. Oid means like. Remember this, right? I told you the dictionary. The dictionary has most of the meanings. Oid means like. Fibrinoid means it's a fibrin-like necrosis. That's all, right? So fibrinoid by default, the literal meaning is it's a fibrin-like necrosis. Anywhere you use the term oid, it is like lymphoid tumor, lymphocyte-like tumor, myeloid tumor, myelocyte-like tumor. Fine. About the gross lung pathology, this is the example of caseous necrosis where it's white in color, right? Microscopy we'll see when we go to granulomas, right? Anything oid means it is like, right? Leukemoid, leukemia like, right? Colloid, collagen like, thyroid, shield like. It's like, oid means like, that's all, right? So fibrinoid means fibrin like necrosis, right? Tell me, where have you heard in your physiology fibrinogen being converted to fibrin? Which pathway? Where have you heard fibrinogen becoming fibrin? Anywhere? Clotting cascade? That's where you're right. Perfect, Pare. Right? So when I have read that in clotting cascade, so this mechanism also is something related to that, right? In other words, when do I have a clot? Whenever which is injured, whenever vessel is injured, right? Only when a blood vessel is cut, it will bleed, and only when it bleeds, I'll have fibrin. Fibrinogen getting converted to fibrin, right? In other words, fibrinoid necrosis is equivalent to vessel wall necrosis. It's nothing but vessel wall necrosis. Remember this. When you revise pathology, you have to revise with only keywords, nothing else. Fibrinoid means vessel wall. So can I say any disease which will damage the vessel can have fibrinoid necrosis? Is that statement right? It's vessel wall necrosis, that's all, right? So where do I see fibrinoid necrosis? You can write any disease which involves vessel. Okay, any disease involving vessels, it can cause fibrinoid necrosis. Whatever in the earth I have a vascular disease, by default it causes fibrinoid necrosis, right? Few examples. What do you call the term for inflammation of vessels? For any vessels or any inflammation, we add the term itis, right? Inflammation of vessels, vasculitis. So for vasculitis, you'll have fibrinoid necrosis. When you go to blood vessel chapter, we'll read like 5, 8, 9 types of vasculitis. All the vasculitis will have fibrinoid necrosis by default, not just one. Any vasculitis you know, they will have fibrinoid necrosis by default, right? Second, I have a type of vasculitis called as an SLE. SLE is systemic lupus erythematosus. We'll read them when you go to immunology chapter. Remember, there's a disease called as an SLE. SLE also will have fibrinoid necrosis, right? Next, I have a type of hypertension called as malignant hypertension, right? What's a normal blood pressure? 120/80, right? That's approximately the normal blood pressure, right? So malignant hypertension, the BP will be approximately in the range of 200 millimeter mercury. Okay, 200 millimeter mercury. That's how it will be. That's very, very, very high, right? So let's say you must have read in your physiology again. Arterioles are also called as resistance vessels because that's the one which provides the total peripheral resistance, right? Have you heard this statement in physiology? Right? SLE is Monisha systemic lupus erythematosus. Don't worry. Few time you will definitely know what SLE is. Just few minutes. Fine. Okay. Perfect. So arterioles are resistant vessels. So imagine a tiny arteriole having 200 millimeter of mercury. Can it rupture? Systemic blood pressure 200. Yes, Kumar. It's a very high degree of hypertension. This will undoubtedly rupture vessels. So when blood vessels are ruptured, I will end up in having a fibrinoid necrosis by default, right? So that's why it's a vessel wall damage. You'll have fibrinoid necrosis. Fine. Okay. Last but not the least, we have a condition called as rheumatic heart disease. Have you heard about this condition, rheumatic heart disease? Now itself I'm saying most of you will pass your final year based on that, right? It's called malignant. It's not because of cancer. It is lethal. If you have 200 millimeter of mercury, if all the CNS vessels dies, ruptures, the patient might die. We might lose the patient. That's why it's called malignant, right? So rheumatic heart disease, RHD. I have a finding in rheumatic heart disease called as Ashoff bodies. Again, we'll read this when we go to your systemic pathology. In Ashoff body, I will have the same fibrinoid necrosis, right? The reason why I'm saying rheumatic heart disease also have this is heart is the biggest vessel. We have tunica intima, media, adventitia in blood vessel. We have endocardium, myocardium, pericardium in your heart. Same, but more thicker, right? Heart also comes in the cardiovascular system, right? It's same, right? So I have these conditions. All these conditions, you'll have fibrin-like necrosis, fibrinoid necrosis, right? This is the image given in Robbins. Okay, let's decode this image. Okay, colors are everything, right? Colors are everything. So what do you think? Tell me, what color is this? These are simple questions, right? If you can answer these simple questions, you can master pathology. Red color, right? Okay. Heart is the heart of CVS. Yes, obviously, Lakshman. Right? It's red in color. Red color means, what is red color in my body? Blood. That's blood. So if something in the center has blood, can I call it a blood vessel? That's obviously a blood vessel, right? So this entire structure for me is a blood vessel because it has blood in the center. Remember from now, in order to identify a blood vessel, don't go with tunica intima media adventitia. You cannot. No one can. Center empty, center RBC. That's a blood vessel. Don't complicate medicine. Medicine is very, very simple, right? So I have a lumen, I have a blood vessel, right? So in the wall of the blood vessel, can I say there's an area which is completely pink in color with very, very, very blue color? Can I call this area necrotic? If it's pink in color, only pink in color, I can call it necrotic. So in the wall of the blood vessel, I have an area of necrosis or a pink color. I call it fibrin-like necrosis, fibrinoid necrosis, right? As simple as that. Images and drawings are very, very easy. You learn why it is, you'll never ever forget it, right? It's very simple. That's how fibrinoid necrosis, right? Now let's come to fat necrosis. Quite a few of you guys had doubt that whether pancreatitis will cause fat necrosis or not. We'll solve that doubt very soon. So in fat necrosis, I have two different types of fat necrosis. I think in Robbins, only one type is much more explained in detail, but I'll talk about both of them because both are required, right? So one is traumatic fat necrosis. Okay, one is traumatic fat necrosis, which is trauma-induced fat necrosis. The other one is enzymatic fat necrosis, right? One is trauma-induced, other one is enzyme-induced fat necrosis. Traumatic fat necrosis is very simple. You have a structure rich in fat. You destroy it. Will it have fat necrosis? Definitely, right? Breast parenchyma, gluteal region, abdomen, belly fat. I destroy the fat, I'll have trauma-induced, I'll have fat necrosis, right? Let's say someone has got an injection in the gluteal region. Can it destroy the fat in the gluteal region? No, Abir, once the blood vessel is ruptured, it's lost. It's completely lost. That will lead to problems in different organs wherever it's getting ruptured. Fine. It will, right? By default, right? Some portion by default, right? Traumatic fat necrosis can happen in the breast parenchyma, can happen in the gluteal region, can happen in the belly, abdomen. Wherever I have trauma, wherever I have fat, whatever be the trauma, it can cause necrosis. As simple as an injection. Injections can cause necrosis, right? You will learn in pharmacology insulin. Can I say insulin injection is given in fat-rich structures? Prakar, when necrosis happens, every necrosis is painful. Fat necrosis is also painful. It might not cause too deep necrosis, Punit. Mostly it will be superficial, right? So insulin injections are actually given either in the deltoid or in the abdomen or in your thighs. So can an insulin cause fat necrosis? Definitely. I'm removing that extra tissue, right, Bhumika? It will cause it, right? It will remove, right? Now tell me, I'm just going to ask you a question because quite a few of you answered insulin is given in abdomen. If you remember 20 years back, insulin was given here. Why did we change to abdomen? The answer is fat necrosis. The understanding changes everything. If I keep on giving insulin in my deltoid every day 2 times or 3 times, will I destroy this deltoid fat? I will. Once the fat is completely lost, will I give insulin in fat or muscle? What happens? Once it's completely lost, I'll give it in muscle. I should not give insulin in muscle. That's the reason I went to abdomen, because abdomen is huge. I start from here, I go completely in circles, and then when I come back here, that time the tissue will be healed. It's more surface area. That's the reason we preferred abdomen, nothing else, right? Now, when you go to pharmacology, you will read a side effect, and we will name that side effect today. I am destroying, giving more and more and more injections. I am destroying fat. The fat reduces in size and shape. What is the adaptation called as? Something reducing in size and shape. What is the adaptation called as? We call it hyperplasia, metaplasia, hypertrophy, atrophy. We call it atrophy. Perfect. Wait there. We also will read soon something for abnormal atrophy, because it's not a normal atrophy, it's pathological. I'm just injecting and causing destruction, right? So can I call it dystrophy? Abnormal atrophy is dystrophy, right? Sushmita, they would have necrosis because of the cell damage. That's what it is, right? It's dystrophy, right? When you go to your insulin chapter, or you take Tripathi or whatever book you follow, go to insulin, there'll be a side effect called as lipodystrophy. It's simple, lipodystrophy. Everything in medicine can be named and we'll never ever forget it. Now tell me, if I have an MCQ which says that only insulin causes lipodystrophy, or any subcutaneous injection repeatedly can cause lipodystrophy, what's the answer? It's any subcutaneous tissue, right? Gauri, there's nothing in fat necrosis, traumatic. You damage it, it's destroyed. That's what it is, right? It's anything. Don't go for MCQs. We'll read the concepts. We'll never ever make a mistake. Okay? Right? Perfect. Let's go back. You must have heard about lipodystrophy. If not, this is the reason. Fine. Let's go to enzymatic fat necrosis. Enzymatic fat necrosis happens in acute pancreatitis. This is the etiology for enzymatic fat necrosis. Let me complete and then ask the questions on enzymatic fat necrosis. We already learned about acute pancreatitis recently. What's the type of necrosis in acute pancreatitis? Anyone? Coagulative, liquefactive, fibrinoid fat. It's liquefactive, right? So here in the substance of pancreas, what happens is I'll have liquefactive necrosis. Okay. Now let's go to yesterday's class. What we read was, during necrosis, what happens to the cell membrane? Intact or ruptured? During necrosis, is it intact or is it gone? It is gone. So can I say this lipase can diffuse outside the pancreas, or they will be only in the pancreas? It will diffuse outside. Can it go to the omentum? It can go to the omentum, right? What is omentum made of? You must have seen omentum in your anatomy dissection. Omentum is yellow in color. Omentum is made of fat, right? That's all. So this pancreatic liquefactive necrosis, obviously lipase will leak out, like you said. When it leaks outside, it can go to two places. One, the easiest one is omentum, and also surrounding the pancreas, I do have a little bit of fat. That also can be destroyed, right? We call it an peripancreatic fat. Okay. So omentum and peripancreatic fat, what type of necrosis we'll see? Fat or liquefactive? Here we'll have fat necrosis, right? It's very simple to remember. Fat necrosis will happen in fat-rich structure. Is pancreas made of fat? If it is diffuse necrotizing appendicitis, when it goes outside, it can cause punit. Generally, appendicitis is a luminal pathology, not the serosal. If it goes to serosa, it can cause. It will happen in fat-rich structure only. It cannot happen anywhere, right? Okay, perfect. So it will not happen in pancreas because pancreas is not fat-rich. Only omentum is fat-rich, peripancreatic fat is fat-rich, pancreas is not. So there's no confusion. So if any question comes or in a viva, listen to the question carefully. In acute pancreatitis, in the pancreas, you'll have liquefactive necrosis. In the omentum or in the peripancreatic fat, obviously you'll have fat necrosis. That's all. That's it. Very, very simple, right? Now let's go back to our older one. Yes, Tendulkar, everything will be released, but amylase is not going to cause fat necrosis, so only I didn't discuss about that here. When we go to pancreatitis, we'll definitely talk about that, fine? Now, in yesterday's class, we did read something. What's the most common ion in irreversible cell injury? Irreversible cell injury? Calcium? Okay. Now let's take pancreatitis here again. Okay, let's take pancreatitis. And there is necrosis happening again and again in omentum. Fat necrosis happening again and again and again in omentum, right? So now, what can anyone tell me what is the etiology of pancreatitis? What causes pancreatitis? Neha, when I say structure, the organ structure will be intact, not the cell membrane. Cell membrane will die in every necrosis, Neha. Okay? Infection is not the cause of pancreatitis. Alcohol. Alcohol is the most common cause of acute pancreatitis, right? That's the cause, etiology, right? Now tell me, will an alcoholic drink only for one day or every day? Alcoholics, only one day, every day. Tubule is a structure, not the cell. The cell of the tubule is definitely dead every single day, right? So can I say, which one, Sumit? I'm not ignoring Sumit. I'm having two screens. That's why it's a concern. When the lipase leaks out, they go and destroy the omental fat, Sumit. Fine? Every day, right? Let's come back to this. Can I say in the omentum, every day lipase will go to the omentum? Yes. Every day it will destroy the fat in the omentum? Yes. Calcium keeps on accumulating in the omentum? Yes. Every single day. Will my WBC be very good enough to clear it every day, or sometimes it can accumulate? Occasional drinker will not have pancreatitis, Lakshman. Alcoholics and smokers are always chronic and continuous. There's nothing called occasional or acute. It will, right? So what happens is, when the necrosis is recurrent, so here the calcium accumulates along with the fatty acids, it will form calcification. Robbins talks about a different term here, though the term is not useful. The term is called as saponification or soap formation, because it is involving fatty acid. Soaps are nothing but fatty acid, that's all, right? So it's a calcification at the end of it, fine? I don't ignore anyone, Sumit. It's too much of comments in two screens, so I might ignore sometime. Please put your comment again, I'll definitely answer your question, fine? Recurrent matlab, again and again and again. That's recurrent, fine? So when it happens again and again and again, I'll have this problem, right? Now tell me, you must have read this in your Robbins. These are the calcific deposits, the white areas. This is the background omentum here, the same image in Robbins, and these are the calcific deposits, okay? Now I want to ask you a question. Listen carefully and answer. Is this a problem only in fat necrosis, or is this a problem in any necrosis if they are recurrent? Only in fat necrosis or any necrosis? Any necrosis? Obviously any necrosis, right? Because every necrosis, the calcium is what is going to get accumulated, right? I will change the question, okay? Tuberculosis, TB, acute or chronic? Definitely chronic, right? I'm having a lymph node which is having tuberculosis. Is there a possibility for me to see calcification there? Because TB is chronic. I'll have it by default. I'll have it by default, right? Okay. So now, insulin injection, acute or chronic? Chronic, every single day. Traumatic fat necrosis can also have calcification. It can have calcification. So it's not just omental pancreatitis. Yes, Bhavana, it happens in omentum, right? Anything which is chronic over the period of time, any necrosis will accumulate calcium, will cause calcification. The only thing is it has to be chronic. It has to be chronic, then obviously it will cause. Acute, once a cell dies, WBC will clear them. If it's repetitive, it will definitely cause a problem. Fine, perfect. Those are the 5 different types of necrosis, right? Okay, so we know about coagulative, liquefactive, fibrinoid, fat, and because the most common ion in irreversible cell injury is calcium, Tendulkar. That's why it accumulates. Fine, We have seen all the basic 5 different types of necrosis. Saranya, DCIS is ductal carcinoma in situ. It's a breast cancer's precursor. We'll read them when we come to breast cancer, right? Okay. Okay, got it. Any doubts in necrosis? If not, let's go to the next one. This is omentum, Kumar. This omentum, it's not pancreas. In pancreas, I will not have fat necrosis. Pancreas will have liquefactive necrosis, right? Fatty acid is what soap formation is. Soap solidifies. When I solidify fatty acid, it forms soap. Here, the fatty acid is becoming a little bit solid because of the calcium, so we call it saponification. Not exactly right term, but it's completely calcification. Fatty acid will be the telgar, so it binds to them and form calcification. Okay, clear? Let's go to the next guy. The next guy is apoptosis. Okay, they have taught you in your college. It's actually not apoptosis. That's how I was being told in my second year. Till my final year, I was telling apoptosis, only apoptosis, right? So then someone told me, I had a beautiful senior assistant. He was the one who said, changed my entire perspective of medicine, right? He said that it's not apoptosis, it's apoptosis, right? The apop is different. The P here is silent, right? Tosis means drooping of eyelid. Tosis means drooping of fallen, right? So everything has a meaning. It's apoptosis. Won't my body have the anion, Snegajit? Sanya, in chronic, because chronic more and more calcium salts accumulate, and my WBC is not good enough for them to clear it, so it accumulates. Fine. Okay. Apo means precursor. Hi Suraj, right? It's a precursor to a cell's fall. That's apoptosis, right? It's precursor. You must have read about apoproteins, apolipoprotein, right? That's precursor. Apoptosis, it's precursor to cells falling, or the entire mechanism which describes the cell death is called as an apoptosis. That's why we also have one more name. It's programmed cell death, because it's completely organized. It's step by step is what happens. Fine. Every calcium hit, every calcium will have every necrosis will have calcium. Fine. In acute pancreatitis, I might not have, but in chronic, I'll have. Calcification can happen in any necrosis, but in omentum, I'll have fat necrosis and calcification. Clear, Tanmay? Okay, perfect. So it's a programmed cell death. Okay, it's completely programmed and follows everything step by step, and we call it a programmed cell death. Fine. Okay, this is just a tiny definition if you want to start with for an essay question. This is exactly from Robbins. So it's a programmed cell death that plays a critical role both in physiological and pathological process, right? Okay, we'll look why pathological and physiological here, and we'll look why only pathological in necrosis once we complete apoptosis, and we can tabulate the differences. That can come as a 5-mark question for you. Fine. Okay, right? So what happens in apoptosis? It's both physiological and pathological. Can anyone tell me in which physiological condition my cell will die? Anything which comes to your mind? Anything which comes to your mind where physiologically the cell will die? Okay, these are conditions. Definitely cell dies due to normal physiological process. Anything? Everyone must have experienced it. Why embryological? Embryological by default, yes. Bone growth, amazing. Hair fall? Everyone has had hair fall, right? Hair fall, right? Hair fall is a physiological cell death. From the thing it falls. Skin dies every day, right? RBC dies every day. Thymus dies every day, right? Many examples, right? Hair fall is something which you can never forget. Every single day, it will remind you physiologically cell can die, right? Does hair fall pain? Does hair fall pain? It pains here. It does not pain here, right? It does not pain here because it's not necrosis. If it's necrosis, there'll be pain. It's apoptosis. That's why there's no pain, right? So everything whoever has created us, be it God or be it nature, whoever you going for, is an amazing person. They have orchestrated that I need a painful type of cell death and I need a painless type of cell death. So whatever is physiological dies in the painless way, so it won't harm us. Whatever is pathological mostly dies in the painful way, so that they can come to a doctor, right? That's how it is. That's beauty, right? We have to enjoy it. Okay. Uh, Telomere sequence end could be the reason for cell aging, but not for every other condition. We'll look into it soon. Fine. So I can have many physiological examples. I'm just going to write whatever you guys said. Embryological. There are many examples for embryological. You can write your thyroglossal duct going outside, cyst, thyroglossal duct disappearing, notochord disappearing. Your fingers will have webs if you remember embryology, and it became fingers by destruction of the webs in between the fingers, right? All of them are physiological examples of apoptosis. You can write an entire line based on that, right? Next, we'll go to other things, right? Cell death of skin. Skin and hairs recycling or cell death every day. Every day it dies by apoptosis, right? Now, I'm just going to ask you a simple question. You tell me yes or no. A person who has an infection, right? Nails are not living, they are dead. Nails don't die, they are dead tissue, right? A person having an infection, I got a prick here, I have an infection here. I have 2 bacteria, just for example, and 10 WBC comes into the place. 2 WBC is enough for me to eat the 2 bacteria. What will the 8 WBC do? Will they go back into the circulation or they will die? What do you think will happen? After inflammation, excess of the WBCs, will they die or they will go back into circulation? They will die, right? I just gave an example, right? I just gave an example of two things. Excess WBC, right? So excess of inflammatory cells will die by apoptosis. Not the routine ones, excess, whatever is in excess will die by apoptosis, right? Next, self-reacting lymphocytes. Should they die or should they remain? Self-reacting lymphocytes. They should by default die. That's what thymus does. Thymus removes all the self-reacting. Self-reacting means lymphocyte which considers my body as foreign. Which one, Darshan? Because they are excess, right? It's very difficult for them to go back inside, so they should die, right? So excess inflammatory cells, self-reacting lymphocytes will die, because if they don't die, you'll have autoimmune disorder, right? They should die by default. It's also kind of a developmental process. All these are examples for physiological apoptosis. Your endometrium after menopause, apoptosis. Breast parenchyma after menopause, apoptosis, right? All of them are apoptosis, right? So I can have endometrium after menopause, after the hormonal thing stops. That also is undoubtedly apoptosis, right? Now I'm going to ask you a simple question. Let's see if any one of you can answer. We did read endometrium involuting and embryological thyroglossal tract and everything disappearing in one of the cellular adaptation. What was that? Which adaptation we read? Bhavna, self-reacting lymphocytes means when I develop as an embryo to a fetus, child and an adult, there are few lymphocytes which will consider my own cell as foreign. Those will be recognized by the thymus, and the thymus will remove them or kill them. If they don't kill them, my body will have autoimmune reactions, right? We read that in atrophy. Perfect. Now tell me, what is the difference between atrophy and apoptosis? Let's see if you have understood it. Darshan, I said that we did read that involution of the endometrium after menopause and embryological thing, also an atrophy. What is the difference between atrophy and apoptosis? No, this will be painless, right? Both are painless. What's the difference between atrophy and apoptosis? Apoptosis is one of the mechanisms of atrophy. Amazing, you're right. I'm looking for one particular answer. Let's see if I get the answer. And I have told you that when we discuss atrophy also. Okay, atrophy is gross or microscopic? Atrophy is gross or microscopic? Perfect, Sneha says. Atrophy is a gross terminology. I look in the microscopy and call it apoptosis. I look at the gross and I call it atrophy, right? So next thing, apoptosis is a microscopic form of cell death. Both apoptosis and necrosis are microscopic forms of cell death. It's not in gross. I cannot look at the organ and say it's atrophy, it's apoptotic. I can say them looking at microscopy, but atrophy is a gross terminology, right? That's the only difference. Those involution is also irreversible in atrophy, because atrophy can be both reversible and irreversible, right? Perfect. Okay, great. So there's all the physiological ones, right? Let's see what are the pathological cause of apoptosis. Pathological cause of apoptosis, one of the commonest thing is DNA mutation. DNA mutation will kill the cells by apoptosis. That's one thing. Second, I can have viral infection. Viruses kill a cell by apoptosis. Sometimes by apoptosis, sometimes by necrosis. We'll see that very soon. What are the differences? Fine. Okay. Next. Third, I can have intracellular protein accumulation. Anywhere when you have intracellular protein accumulation, any protein accumulation, that will kill the cell by apoptosis. Okay. These are three conditions where I can have cell death by apoptosis, right? This is what bothers the entire medical fraternity, because when a cell has DNA mutation, it kills the cell maximum by apoptosis. Painful, painless, right? So can anyone or any patient can detect mutation happening in the body? They can't. So will they come to the doctor? They won't. So will it go unnoticed? It goes unnoticed, right? That's why I am not able to identify cancers very, very early. Cancers start with mutation. If I had gotten it that point of time, we can easily treat it. The problem is cancer accumulates so many mutations, nothing is painful, everything is slow and painless. Only when I visibly see the tumor 2-3 centimeter, then I go and have a problem. That's the problem, right? Have you heard about Alzheimer's disease? Alzheimer's disease, Parkinson's disease, you must have heard about them, right? Alzheimer's, Parkinson's, Tanmay said cystic fibrosis, right? All of them have protein accumulation. When I have intracellular protein accumulation in my basal ganglia, it kills the basal ganglia, no symptom. Only when my rigidity happens, only when my tremors happen, the patient come to a doctor. Only when the patient forgets, Alzheimer's is being picked up, right? That's why these are very, very difficult, right? So if any one of you in future can identify apoptosis using a simple blood test, you will really create a wonder, because there are multiple diseases, most of the diseases which I don't have a treatment for now. The cell dies by apoptosis. PCOD, PCOS, why? Why suddenly in between? That's a hormonal problem, right? Okay. So there are multiple things, multiple pathological things still that I don't have a symptom yet. The symptom happens after organ dysfunction, right? Dashwin. Okay, Dashwin, yes, in polio what happens is it's denervation. The nerve dies. Nerve dies, because of that, uske baad you will have definitely problems in your muscle. That's a secondary muscle degradation due to nerve damage, right? Okay. Is dementia occurs in Alzheimer's, but it's a very late stage. Okay. Fine. Got it? That's physiological and pathological, right? Now let's have an overview of apoptosis. What exactly happens in apoptosis, right? I have two stages in apoptosis. One is something called an initiator phase, which is starting point. Okay. Nerve dies because of the viruses. Right? So virus will destroy the nerve. Fine. Then it will go to something called an execution phase. So I have initiator phase and execution phase. In the initiator phase, I have two pathways. One pathway is for us, your extrinsic pathway. What do you mean by extrinsic? Extrinsic means inside or outside? Extrinsic is outside. Extrinsic or cell membrane mediated pathway. It's based on the cell membrane. That's outside or extrinsic, right? So the other one is intrinsic pathway. It's from the inside. It happens from the inside. It is due to mitochondria. Mitochondria plays a major role here. It's from the cells inside there's a trigger, so we call it an intrinsic pathway. Both of this pathway will end up in having execution phase. Same execution phase. Execution phase will not have two different things. Execution phase will have only one outcome, but initiator phase has both extrinsic starting or an intrinsic starting based on the stimulus, right? Most of the time, viruses trigger intrinsic pathway. Your DNA mutation is the most important trigger for your intrinsic pathway. Virus for extrinsic and DNA mutation for intrinsic, right? I have two etiologies. Can anyone tell me which you think will be common? Which will be the common one? Extrinsic or intrinsic? Think carefully and answer. You need not be the first one to answer. I want you to be the right one to answer. Anything. Extrinsic. Intrinsic. There's a tug of war between extrinsic and intrinsic. Fine. Okay. Now let's take two different things, right? I have a virus. Let's take you. You must have had a viral cold for sure. Once in 2 months, once in 3 months, just for random thing. Yes. When you go out in sun every day, will you have a mutation? When you go out in sun every day, you have a mutation by default. Again, mutation is unnoticed. No one knows when the mutation happens, but every day you'll have mutation because UV rays is radiation, right? UV rays is radiation. It will be corrected. Cells will die, cells will not die, right? This is undoubtedly the most common, though it's not significant. It may be very silent mutations, but mutations are very, very, very common compared to viral infections, right? So that's why intrinsic pathway is the most common initiator phase compared to the extrinsic pathway, but both of them do exist. Fine, perfect. Because DNA mutations are not noticed, we generally ignore that. Fine, perfect, great. Now let's go to extrinsic or the cell membrane mediated pathway. Okay. What we will do in both understanding of intrinsic and extrinsic is we learn what is normal first with a simple example. Gade, you are using iPad. iPad has few glitches. Rest of them is decent. If you're using iPad, we'll definitely try to solve it at the earliest. Fine. We'll look at a normal cell, normal viable cell, what happens, and also we'll look at a activation. Once it's activated, what's going to happen, right? So now, when you have a extremely normal viable cell, viable means normal living cell, which is not having any infection or any mutation, which is causing the disturbances. Fine. Okay. Extrinsic pathway. What happens is I have something called an FAS receptor. I have a normal cell which has a receptor on the surface. What is an FAS receptor? This FAS receptor has multiple names. It's also called as CD95. It's also called as death receptor. So all these are different exam names given for them. So one exam they might ask you FAS, one exam they might ask you CD95, something like that, right? So it's also a receptor which happens new TNF superfamily of receptor. It's a type of TNF receptor in the family of receptors, right? There's a receptor normally present. Nothing will happen. It's a receptor present there. That's all, right? Let's assume this normal cell is getting infected by virus. Just for a name's sake, it's getting infected by virus. Which WBC will try to eliminate viral infection? Neutrophil, lymphocyte, eosinophil. Which WBC? Lymphocyte. Have you heard about a lymphocyte called as CD8 T cells? Lymphocytes, right? Perfect. Let's assume this cell has got the viral infection, so automatically a lymphocyte will come and try to eliminate them, right? Viruses are mostly tackled by lymphocytes, right? So what happens is when the lymphocytes comes here, I'm just writing L for lymphocyte. Okay, let's write lymphocyte only, right? So this lymphocyte knows that this cell has virus. Okay, this cell has virus here, right? Viruses are obligate intracellular organisms or extracellular? They are obligate intracellular, right? So the only way to destroy a virus is kill the cell. Once you kill the cell, virus cannot survive. That's the mechanism of cell death here, right? So this lymphocyte has the ligand, FAS ligand or FASL, right? FAS ligand, right? And this ligand will come and bind to the FAS receptor on the cell, on the infected cell. Lakshman, but for neutrophil will not help in a viral infection. Only lymphocytes will help in a viral infection because they are intracellular. Neutrophil generally takes care of the extracellular infections. Fine. Okay. Perfect. Let's assume this. Fine. FAS ligand and FAS interaction, right? So FAS receptor, the ligand binds. So will it activate the receptor? It will. Downstream pathways, it activates lots of domain called as FADD, which is FAS associated death domains. It's an activation, that's all. Okay, if you remember this or if you don't remember, doesn't matter for us, right? It's FAS associated death domain. This will be activated. It's like normal receptors and this downstream pathway will be activated, right? This FADD will activate something called an procaspase. Procaspase is an inactive form or an active form. When I use the term pro in front of any enzyme or any protein, active, inactive, it's inactive, right? Pro-insulin, pre-pro-insulin, you must have definitely read about them, right? It's an inactive form, fine. So once this procaspase 8 will be converted, 8 or it could be 10. Both of them is involved in the extrinsic phase only, right? This will be converted to an active caspase 8. We'll stop with this for the extrinsic pathway. Once we complete the intrinsic pathway, we'll take this, right? This active caspase 8 is what will trigger the execution phase. Like I said, the starting point is different, ending point is same, execution phase. Clear? Okay, I'll repeat once again just for clarity. We had a normal cell, normal living cell with the receptor. No activation, no problem. When a virus comes into the place, my lymphocyte came and gave the ligand. And the ligand will bind only when the virus is infected. So when they bound, the downstream pathway got activated, that is FADD got activated. FADD converted procaspase 8.10 to active caspase 8.10, right? Okay, we'll learn one more thing here. How many of you had COVID? This is a random question. Quite a few of you must have had COVID, right? Perfect. So can I say COVID taught us one thing? Virus will never, no, active caspase 8 or active caspase 10, right? Virus will never stop, right? Virus will always keep on mutating and will escape my immune system and infect me again, right? Lakshman said he got 2 times. Quite a few of you must have got 2 times, right? I had an infection, I had an immunity, virus came, mutated, escaped the immunity and got me infected again, right? Do you accept that virus mutates a lot? COVID created alpha to zeta, right? A to Z, everything COVID created, right? So now let's assume the body got the virus. Next time the virus comes, the virus will know, okay, this guy activated caspase and they killed me, right? So will virus create a plan to destroy them? So few of the viruses, what they do is, they have a protein called as flip, okay? So viruses, few of them, to escape the immune system, they produce a protein called as flip. Flip will kind of block this binding, because FADD binding with procaspase, flip will block. So ultimately, flip will not let the procaspase activate into an active caspase 8 or 10. So can I kill the cell or not kill the cell? Neha, this entire thing is a virus cell, okay? I just put a cell, round thing as cell, and top of that the receptor, fine? Yes, Neha, only virus interacting, this is the abnormal. After virus, there's an interaction, fine? It will not kill the cell, right? That's how viruses, few of them can escape the apoptosis and they can live there forever, right? Just remember that this is how it is. If virus has a plan, we will also have a plan for it. We'll look at that very, very soon, fine? So this is what happens here, right? This is for the extrinsic pathway. Clear till this? Let's go to the intrinsic pathway. Intrinsic is mitochondrial mediated. Yes, Bhumika, what request? The last part, Tanmay, is I have an enzyme, protein called as flip. Flip will stop the activation of the procaspase to an active caspase. It will bind there and it will destroy it. Once it's destroyed, I cannot kill the cell with the apoptosis. So the virus survives. That's a mechanism for the virus to escape. Receptor is always on my cell, be it normal or be it viral infected. Okay, clear, Himanshu? No, virus does not have FAS. Okay, it's a, sorry, this is not the virus, this is the cell with virus inside. Clear? Darshan, Himanshu, that's a cell with virus inside. This is a normal cell, right? I have a normal cell which has the FAS. When it's getting infected by virus, this lymphocyte gives me the ligand. Before that, a lymphocyte will not identify a cell, right? Only after the virus comes inside, it will identify the cell and it will destroy it. Clear? Flip is, this is how I destroy a virus. or I destroy the cell, so the virus will be destroyed. So flip is produced by a virus to escape the mechanism of apoptosis, because flip will block the conversion of procaspase 8 to an active caspase 8. Clear, Bhumika? Kumar and Darshan? Fine. FAS is a receptor normally seen on a cell. It is inactive. FAS will become active once the ligand binds, and the ligand comes from the lymphocyte after infection. Great. Okay, let's go to intrinsic or the mitochondrial pathway. Okay, perfect. So I do have few proteins and few genes for us to read before understanding what happens in mitochondrial pathway. And all these proteins are located in the outer mitochondrial membrane. That's how they are located. Gene obviously will be there in nucleus. Fine. I did post today also, Lakshman. Virus will automatically expose the lymphocyte. Once the cell gets infected by the virus, lymphocyte will definitely come inside. That's how immunity works, right? I cannot break that, so I break the activation. So it's not destroyed. Fine. Okay. It's in the outer mitochondrial membrane. Genes are obviously in the nucleus. The protein is expressed in the outer mitochondrial membrane, right? And all these are called as BH proteins, because we have three groups of proteins: anti-apoptotic proteins, pro-apoptotic proteins, and one more thing called as sensors of cell stress. Okay, all these are three groups of proteins, and all these proteins, molecular structure wise, they have some domain called as BH domain. There are multiple protein domains. You must have read a few of them in your biochemistry, right? So if I had all the four domains, 1, 2, 3, and 4, I call it anti-apoptotic. If I have only BH1, 2, and 3, it's pro-apoptotic. If it's BH3 only, right, it's missing BH3 only, which means the third BH3 alone, I call it sensors of cell stress. That's how I molecularly categorize these three of protein. BH is a domain in the protein structure. Fine here. Okay. You have multiple domains. You have theo domains, thioester domains, like that. BH is a domain in the protein structure. Fine. Okay. So based on the molecular protein categorization, I divide them into anti, pro, and sensors of cell stress, right? So now there are multiple genes or proteins under the anti, under the pro, and under the sensors of cell stress. So how do I remember that? Just tell me a simple trick to remember. Any trick which I tell is given by my senior. It's not by me, right? Tricks, I am not able to create good mnemonics and tricks yet. Hopefully in future I'll improve. If a protein is causing anti-apoptosis, what will happen to the lifespan of the cell? Will it be long or short? The lifespan of a cell, it's anti-apoptotic or stopping the apoptosis. Lifespan will be longer, right? So every anti-apoptotic protein will have a very long life, right? Just a way to remember, if something is L in its name, which will be anti-apoptotic, right? So in other words, L is the clue: BCL2, BCLXL, MCL1, right? Most of the anti-apoptotic gene will have L in its name. Exception is this guy. The only problem with tricks is they will not stay there for a long time. I have one thing which is BCLXS. Maybe remember S for short. That is pro-apoptotic. Though it's not an important thing, this might confuse in an exam, right? Most of the things which has L in its name are anti-apoptotic, because a fact which you have to remember, right? And pro-apoptotic is two things: PAX and PAC. These are pro-apoptotic, and you have 5 of them for sensors of cell stress. Just remember, these are terms. We'll see how it functions very soon. BIM, BIT, BAT, Puma, Noxa are sensors of cell stress, right? Again, we'll see what will happen to a normal cell when it's living, and we'll also see what happens when there's a trigger, or when there's a trigger for cell death, right? Normal cells, mitochondria. We have a good mitochondria, okay? And this is where I have the proteins, right? A normal cell which will not die, what should be there? Pro-apoptotic or anti-apoptotic? Lakshman, there's nothing much to explain. These are just terms. These are just genes or proteins for anti, pro, and sensor of cell stress. BH1, 2, 3 means this will have 3 BH domains, Darshan. 3 domains, 1, 2, and 3. This will have BH 4 domains. Okay. When I have 4 domains in the protein structure, I call them anti. When I have 3 domains, I call them pro. Fine. Okay. Perfect. So when a cell is living, I should have anti-apoptotic. Only then the cell will not die, right? By default. So what I'll have is, I'll have the most important anti-apoptotic protein for me is BCL2. So what is the function of this protein is BCL2 will actually close the or prevent the exit of one more molecule, right? It prevents exit of cytochrome C into cytoplasm. That's the role of BCL2. It's like a guard which closes the gate, right? If you remember biochemistry, can anyone tell me what is the function of cytochrome C? Function of cytochrome C? Anything which comes to your mind? It helps in electron transport chain, right? So the function is electron transport chain, and electron transport chain happens inside mitochondria. So it's very simple. Cytochrome C should be there inside mitochondria for me to produce ATP and then for us to produce a proper living cell. Yes, Tanmay, doesn't look like a mitochondria. Sorry for it, right? It's a mitochondria, right? So the function here is to produce that. So if a cell has to live, I need ATP. If I need ATP, cytochrome C should be inside mitochondria and BCL2 blocks that. Clear till now? That's how it functions as an anti-apoptotic. Okay, that's how it functions as an anti-apoptotic. Fine. So this prevention will make sure ATP production is normal. Okay, and the cell functions. Fine. Yes, Tanmay. Okay, so I'll write this also. This is mitochondria. Fine. It's present on the outer membrane of the mitochondria. Fine. Okay, clear. This is normal, right? Now let's see what happens when there's an abnormality. If you remember, I told you there's one trigger for intrinsic pathway. What was the trigger? What triggers the intrinsic pathway of apoptosis? Lakshman, it's very simple. For a normal functioning cell, I need ATP. For that, electron transport chain should function, and one of the molecules is cytochrome C, which can actually go outside. So BCL2 kind of blocks that exit. So they can't go outside, so they remain and produce ATP and makes the cell live, right? Perfect. So now let's see what will happen with a cell with an insult. Like you said, insult here is DNA mutation. Okay. So once DNA gets mutated, nothing will happen to pro or anti-apoptotic initially. So this DNA mutation will be sensed by whom? These guys. Yeah, right. So can I say mutation is a stress to the cell? It is a stress to the cell, right? So this is a stress by default. Not just DNA mutation, any stress. The common one is DNA mutation, right? This DNA mutation will be sensed by your BIM, BID, BAT, Puma, Noxa. I'm just reading BIM and BID alone, but all of them will contribute. It will be sensed by the BIM, BID, BAT, Puma, Noxa. So what this BIM, BID, BAT, Puma, Noxa does is, it does two main things. One, it will destroy BCL2, or it will make sure the BCL2 protein is not produced anymore, and it will activate backs and back. Okay. So one molecule can alter the entire gene's function. That's what here happens. One will stop it, one will activate it, right? That's what actually happens here, right? Now, do you remember lacoperon? Biochemistry. E. coli, lactase, glucose, everything. So can I say one event can turn off some genes and one event can turn on some genes? Kind of. That happens in your E. coli. Similar way, this BIM, BID, BAT, Puma, Noxa will turn off BCL2, so it will not be produced, and turns on backs and back. Kind of, right? Kind of the similar pathway which happens in a eukaryote. Lacoperon happens in a prokaryote. Kind of that. This genetic modification happens in the eukaryote, right? I know only a little bit of lacoperon, so don't ask me many questions on that. This is an example of a eukaryotic lacoperon process, right? So now, when BCL2 is gone and backs and back is increasing, backs and back's function is they are actually ion channels for multiple proteins. Okay, one of the important one for us is cytochrome C, right? One by default is cytochrome C. Okay, so cytochrome C is one of the important thing. Okay, Kumar, I am just mentioning all the important ones. Let's leave. There are many things, right? Because if you keep on putting all the BCL, if there is Q, it should start from A, right? Let's stick with this. That's more than enough for us, fine. Bhavna, if why they should destroy them is BCL2 is the guy which is blocking the exit. If it is there, cytochrome C cannot come outside. Only when cytochrome C comes outside, it will destroy, it will die, right? It will die. That's why it is important. Fine. Okay, perfect. Now I said multiple things. One of them is cytochrome C, which is comes outside. If cytochrome C is outside of the mitochondria and comes into the cytoplasm, can the mitochondria produce ATP anymore? Will it produce ATP anymore? It will not. If the mitochondria does not produce ATP, can I say the cell is going towards cell death? It is, right? That's the exact mechanism what happens, right? That's one. Other thing, though not important, might read that. If you answer everything, they might ask you this. So, few more proteins called as SMAC and Diablo. So what this proteins does is they will destroy few things called as inhibitors for apoptosis or IAP. So what happens is in the cell cytoplasm, I already have few proteins which is like a negative control for apoptosis, just a check mechanism. So once the back comes into the mitochondrial membrane, SMAC Diablo goes outside, destroys these inhibitors, so making it ready for cell death, right? Just double assurance, that's all. Because I already have an inhibitor that's inhibited, at the same time I activate it, right? And cytochrome C, once it comes outside, cytochrome C will bind to one more protein called as APAF-A1. Too many proteins, right? APAF-1 is apoptosis. It's simple to remember. AF is activating factor, right? These days when I say AF, something else comes to the mind, right? It's activating factor, right? It's APAF-A1, APAF-1. So cytochrome C binds to APAF-1 and forms a structure called as an apoptosome. Okay. Okay, I'm going to give you one more information now. What does oid means? Just they are proteins. IAPs are normal proteins present in the cytoplasm. SMAC Diablo are there in mitochondria. They come outside and destroy the proteins in the cytoplasm. Fine. Okay, oid means like, right? Never forget that, right? Like that is one more thing. If something ends up with some, they are not single protein. They are a combination of proteins. Lysosome, one enzyme or many enzymes? Many enzymes, right? If something is named as some, it's not a single protein, it's a combination. We'll read lysosome, inflammasome, apoptosome. So which means it's a combination of proteins which is creating a unique structure. It means many. Some means it's a combination of proteins. Again, remember this forever. It might come handy sometimes, right? Now, what happens is the cytochrome C, once it binds to APAF, it creates a structure called as an apoptosome, which is like this. Not exactly like this, with a central lumen. I am not so good in drawing. Okay, let's assume there's a lumen here. It's a machinery which is like this. Fine. So this machinery, what it exactly does is, does the same thing what FADD was doing it. I'll explain Sirasai, the SMAC and Diablo soon. So any caspase which crosses this will get activated. So I have a procaspase 9 which becomes active caspase 9. So it's an activating machinery. The only way to activate a protein is I cut the proteins, right? So imagine it's like a ring. A protein goes through the ring, it's cut and become active. That's what apoptosome does. Apoptosome is nothing but APAF1 and cytochrome C. Clear? Okay, let's come back to SMAC and Diablo a little bit. Though it's less significant, let's read that also. Fine. I have a normal cell, right? Whoever has doubts on SMAC and Diablo, answer these questions so it's easy to understand. A normal living cell, I already have a check mechanism of BCL2. Is it okay for me to have one more check mechanism? Because due to some trauma, if cytochrome C comes outside, I should not kill the cell, right? So that check mechanism is inhibitors of apoptosis or IAP. This is there in the cytoplasm of every cell. Just a second check mechanism. If something comes out by default, I'll destroy them. So once the cell is ready to die, the back comes to the mitochondria. I have two mechanisms happening. One is cytochrome C, which is the main mechanism. Other guy is SMAC and Diablo. SMAC and Diablo comes outside and destroys the inhibitors present in the cell cytoplasm. And cytochrome C binds to APAF1 and activates the pathway. Clear, Sai? Everyone who has a question or doubt on SMAC Diablo? Clear? Fine. So that's what happens. Two things happen simultaneously. This is not very significant, but the most significant one for me is this. Okay, Neha. Why it will not die is, for everything, can I say I need a threshold? Yes. Because it's a very liquid environment in my body. I need a threshold for everything. Only when there's a back, the threshold will increase. Till that threshold, some mistake, it can happen. If cytochrome C comes, it will not get activated, right? So that threshold is maintained by IAP. If something by default comes outside, some error happens, some mistake happens, IAP will take care of that. Once it goes beyond the threshold and these guys comes, it's a signal for death. Fine. Okay. Now you have caspase 9, active caspase 9, right? So that's the stop of your intrinsic pathway. Which part, Lakshman? Tell me which part you're not able to understand. Okay. Now we had extrinsic pathway in one hand. What was the caspase it gave? What caspase did extrinsic pathway give? It gave you know the answer. Caspase 9 or 10. 8 and 10. I'll repeat, Lakshman, once again. And at intrinsic pathway, at the end point, the caspase, what it gave was caspase 9, right? Either of this, 8 or 9 or 10, is enough for me to activate execution phase. That's enough for me to activate execution phase, which you'll see soon, right? Lakshman, what happens here is, once I know there's a threat, it will activate the BIM bit bad. I hope it's clear. Then it will reduce BCL to activate backs and back. Backs and back is an ion channel. So this is also in the outer mitochondrial membrane, which will release all the cytochrome C from mitochondria, and this happens to the cytoplasm. Everything goes to cytoplasm, right? So once cytochrome C comes to cytoplasm, binds to a protein, and it ultimately activates caspase. And this SMAC and Diablo is going to destroy already present inhibitors in the cytoplasm, right? So it's clear route for me for cell death. That's what SMAC Diablo and cytochrome C does, right? Clear? So the end of initiator phase, I have either of these caspases which will destroy it, right? Sure, and I'll do it. Fine, I'll have execution phase, right? So what happens in execution is it's very simple. So execution, either at 8 or 9 or 10, these will activate more caspases, right? This will activate few more enzymes. And we'll talk about the enzymes. There are two main enzymes which will activate. One is obviously caspase. This will activate caspases 3 and 6. These numbers were previously asked in MCQs, but these days they're not asking more of memory based questions. It's more becoming conceptual. So if you're good in remembering numbers, remember them. Smaller numbers for execution, higher numbers for initiation. Just a way to remember it, right? And also this will activate one more enzyme called as endonuclease. Am I right in saying that when we read necrosis, the final step was enzyme activation? Yes, no, maybe? Yes, perfect. Can anyone remember what were the enzymes activated in necrosis? The calcium came inside. What did they activate? They activated 3 enzymes: phospholipase, protease, and nuclease. This is a protease. We'll talk about caspases very soon. This is a nuclease. What enzyme is missing here? What enzyme is missing here? It's clear, right? What enzyme is missing? Phospholipase is missing. Perfect. If phospholipase is missing, in apoptosis, will the cell membrane be damaged? Not damaged. In apoptosis, cell membrane will not be damaged. The cell membrane is not damaged. Will the intracellular content come outside? It won't come outside. If it cannot come outside, will you have an inflammation? There's no intracellular content coming outside. Will there be inflammation? No inflammation. That's why apoptosis does not have inflammation, right? Because it's completely sealed. It's a completely sealed type of cell death, not doing anything to any surrounding tissue. That cell dies because of an intrinsic trigger in the molecular pathway, right? Okay, Clear? Perfect. That's the main difference between necrosis and apoptosis, right? Now let's learn a little bit about caspases. I told caspase is a protease, right? The term caspase, it's actually a protease with cysteine residue. That's an amino acid, right? C stands for the cysteine residue, and they cleave the protein after aspartic acid, right? So caspase by default CAS and base, right? It's a protease. It's a protein degrading enzyme with cysteine residue in the active site, of the protein, and it cleaves after the aspartic acid residue, right? So every protein might have series of amino acid. One of them might be aspartic acid amino acid that it exactly cleaves, right? That's the function of caspases. It's a name. It's caspases, fine. Okay, it's caspases. Yeah, caspase. This makes much more sense, right? Okay, so it's caspases, right? Cysteine aspartic acid residue, it cleaves, right? That's caspase, right? Now let's see, and we have one more protein. We'll talk about the second enzyme also here, endonuclease. Okay, because this basic understanding is very much important for me to know what exactly happens in your cell during apoptosis. Have you read about something called an restriction endonuclease in your biochemistry? Restriction endonuclease can cut a DNA in any site, or restriction endonuclease can cut a DNA only at palindromic sites, which is the right statement. Restriction endonucleases can cut the DNA only at the palindromic site, right? So it's an endonuclease. It's not a nuclease, right? It can cut DNA at palindromic sites. Okay. Now I'm going to ask you a very important question. Listen carefully and answer. In necrosis, I had a nuclease, right? In necrosis, I had a nuclease which can cut any DNA at every site. If DNA is present, nucleic acid present, it can cut. But here, it's an endonuclease which can cut the DNA at palindromic sites. So what will apoptosis cause? Nuclear fragmentation or nuclear lysis? Fragmentation or lysis. Neha, cysteine in active site is every enzyme will have an active site. That's where the enzyme gets activated. At that site, they have cysteine. It'll cause fragmentation, right? Perfect. If it's fragmentation and not lysis, can I tell apoptosis can have the blue color? Is that statement right? It's not lysis. So can apoptosis have blue color? Or no blue color? They can have blue color. Perfect, right? So necrosis is only pink. Apoptosis will have both blue and pink color. We'll see what happens very, very soon, right? Now, let's take a cell. It's a simple normal cell with a good normal nucleus and as usual a beautiful pink cytoplasm, right? Okay, so this cell has two enzymes acting on it. One is your caspase, one is your endonuclease. Fine. Caspase is a protease. When a protein is destroyed, it becomes light pink, dark pink. Dark pink. Will it become precipitated or will it swell up? I'm destroying a protein. Will it become precipitated or it swells up? It will become precipitated, right? Perfect. Okay. Moria, fragmentation is cutting, lysis destroying completely, right? So now when the protein becomes precipitated, what do you think will happen to the size of the cell? Will it become smaller or bigger? Because the protein is being destroyed, is being precipitated. Cell swells or cell shrinks? The cell shrinks. Perfect. What happened in necrosis? There was a cell swelling. Again a difference. We need not read tables, we'll recreate tables, right? The first change is the cell becomes smaller. It'll become a small cell. Cell shrinks because the entire protein is destroyed and the protein is precipitated. The protein precipitation will result in shrinking of the cell and the cell becomes smaller, and in necrosis the cell swells. Fine. It'll become definitely darker pink. Okay, that's by default. The cells will have same increased eosinophilia because the destroyed protein by default will be pinker than a normal protein. Clear? Perfect. Next, let's come to nucleus. I'm having a normal cell, normal nucleus, which is a mixture of euchromatin and heterochromatin. Now the endonuclease comes and cuts them. Once I cut the nucleus, will it be functional, non-functional? It will not function, right? It will be non-functional. If it's non-functional, will it become heterochromatin? Light blue, dark blue? Dark blue, right? Perfect. So can I call this nucleus will become smaller and darker? Yes, the nucleus becomes smaller and darker. It will become smaller and it will become darker, right? So here what happens is the DNA will condense. Okay, this chromatin condensation, the entire DNA condenses. Fine. So it's a smaller and a dark nucleus. Can I call this pycnotic? I can actually call this pycnotic, but the term is not used in apoptosis. The term is used in necrosis. This is also a pycnotic nucleus only. In other words, unfortunately in apoptosis, they call it chromatin condensation. I don't know why they use this. They should have called it pycnotic nucleus. In both the places, it will be pycnotic nucleus only. In apoptosis, it stops here. There, it will lyse. Pycnosis results to karyolexis. Karyolexis will result in karyolysis. That will not happen in apoptosis, right? Okay. So what happens is, when this entire destruction happens, sometimes the cell might not exactly destroy like this. So what happens is, cell might kind of fragment. It may kind of fragment. It will form multiple tiny particles. Okay. So bleb will form and they'll form multiple tiny particles. The reason it's forming multiple tiny particles is it okay for me to eat as a whole cell or break it down and eat, which is easier? Breaking it and eating is easier. So tiny membrane bound particles come outside. These are called as membrane bound particles or membrane bound bodies, and we call these apoptotic bodies. Okay. So we call this apoptotic bodies. Apoptotic bodies are the microscopic evidence of apoptosis, right? Now you are going to tell me how an apoptotic body will look. Smaller than the cell, bigger than the cell? Undoubtedly small. What doubt do we have? Darker pink, lighter pink? Definitely dark pink. Condensed nucleus, normal nucleus? Undoubtedly an condensed nucleus. But the most important thing is it may be with or without nuclei. That's more important. I'll tell you why without nuclei, right? The reason why without nucleus, I'll come to Darshan, just give me a second. The reason why without nucleus, I'll come to that also, Priyanshu, right? So because if I have a single compressed cell with tiny nucleus, I am breaking down to multiple fragments. Is there a possibility the nucleus can go into one fragment and the nuclear material will not be in other fragment? Possible? Possible. That's why with or without nucleus, right? Okay. Which is not shrinking in size? The nucleus, Neha? Because it's heterochromatin, right? Heterochromatin will be dark. Fine. Okay, perfect. Now let's come to your question of Darshans and Kumar. Why should I break it? Which part, Lakshman? The nucleus is becoming darker pink because I have a protein degradation. Sorry, cell. The nucleus is becoming darker pink because of heterochromatin. Fine. Yeah. Now that's a very good question, right? Both. Okay, why with or without nucleus? Let's assume this is the apoptotic. It is a destroyed cell. I'm going to make fragments out of it. I can create a fragment like this. I can create a fragment like this. I can create a fragment like this. Right? So when I create 3 different fragments, the nucleus goes to only one fragment. So the other 2 fragments will not have the nucleus. Fine. Neha, this cell, whichever is shrunken, is what is going to get fragmented. So the fragment is obviously will be smaller than the big cell, right? And the fragment is coming from this cell. So it will be darker pink. Okay, Mukul, what happens here is the no ATP is a very late phenomenon here, Mukul. This happens once the ATP production stops, caspase will be activated, enzyme destroys everything. But there, that's a starting point. That's why there's a difference between necrosis and apoptosis, fine? Okay. Okay, now let's assume that I have this apoptotic, this destroyed cell, right? Now tell me, who should remove this? Or can this cell live in my body forever? Who should remove it? Tanmay has asked the question. Should macrophage remove it? By default, macrophage should remove it, right? Okay. Now, two of you asked me the question. Who was that? Darshan and someone, Kumar. There's no lipase. Why should I create tiny blebs? The reason is simple. If I have a normal cell and outside I have no evidence of cell damage, everything happens inside, how will my macrophage know that there is a damage? Macrophage will not know it, right? If nothing happens outside, there is no signal outside, will macrophage know something has happened or not? It will not know, right? For that to know, I need few changes. Antigen presenting cells or any macrophages, I need few changes, right? That's why I form this bleb. The bleb formation is a signal, right? So the bleb formation gives me few signals called as an eat me signals. Okay, eat me signals is nothing but signals for my phagocytosis. That's all, right? What happens is there are two proteins. Remember these two proteins. One is called as an phosphatidylserine. Okay, the phosphatidylserine. The other one is called as thrombospondin. Phosphatidylserine is very important. Thrombospondin also, do remember it, right? In a normal cell, what happens is they are on the internal aspect. They have few proteins. They maintain the integrity of the entire cell. That's the location and that's the function. Phosphatidylserine and thrombospondin, right? Once the cell become apoptotic, it's not functioning. Can I say these proteins will kind of slowly lose its power or lose its function? It will. So once the cell's protein phosphatidylserine loses its function, what happens is they will lose the entire function, that is to maintain the integrity, and they will flip outside, right? So once it's there, they cannot maintain the integrity and they flips outside of the cell. Once they flip outside, imagine that's like a rubber band holding it. It flips outside. Will the cell fragment? I have some protein which is pulling all the cell membrane because there is internal tension and maintaining the cell structure. When the apoptosis happens, I'm not having energy to hold it. It flips outside. So what will happen to the cell? The cell will automatically disintegrate into tiny blebs, right? So once it flips outside, there's no one to hold it. This results in tiny blebs with who on the outside? Who will be there outside? Can you guys hear me? Just give me a second. Okay, with the phosphatidylserine on the outside, right? So it'll form bleb with phosphatidylserine on the outside. Okay, when phosphatidylserine and your thrombospondin is there on the outside, that will create the signal for macrophage. These two, when they go on the outside, they will signal macrophage or eat me signals, and macrophage will come and engulf or eat the apoptotic body. Entire apoptotic body will be eaten by the macrophage and will be cleared by the macrophage. This phenomenon, we gave a term efferocytosis. Okay, we call it efferocytosis. Did they talk about apoptosis in your college? Lipase is a way of causing a bleb, and this is one more way of causing a bleb. That's all. It's the force which destroys and scatters them into tiny thing. See, these are very fast things, Snegajit. So let's say I'm having a tiny balloon. I'm not able to give a complete analogy here. I'll try to give if you're able to understand or not, right? I have a have you seen few magic tricks where you can have a balloon and you puncture the balloon with needles and the balloon will not burst? Have you seen that? Have you seen that? You have, right? So I can still puncture a balloon with a needle, but still the balloon will not burst, right? That's because of swiftness. I do it very fast. It will not happen, right? It's a simple thing. So now imagine I have a cell with lots of force given by proteins pulling like this. and these proteins are not able to hold the force and it flips. Have you also seen a soap bubble breaking into two individual bubbles without break of the cell membrane? A normal soap bubble what you must have played. Have you seen one bubble become two without breaking? Or a big bubble, you use your hand very fast, it becomes two. You have seen that, right? There's no cell membrane break there, but it forms a blob, right? Same way this happens because it's very fast. The flipping is very fast. It becomes a blob without breaking of the cell membrane, right? Okay. Darshan, this is what I said. I have a cell here which is having the protein which is holding all the cells membrane so that it doesn't break, right? So suddenly this is an ATP dependent mechanism. Suddenly when the mitochondria goes away, I don't have an ATP. So all of them at the same time moves outside. When they move outside, they kind of disintegrate the cell and becomes completely tiny cell. Clear, Darshan? Okay. Aber, I did explain that once again. Can you understand? It's a simple thing. When something is very fast, I can break it without breaking the cell membrane also. Apoptotic body will have an intact membrane. Okay. I think the best example would be soap bubbles dividing into 2-3 pieces when I slice it up, right? Okay, fine, perfect, right? So that's what happens. But once that happened, it kind of eats it. Okay, where was I? I asked the question like, they must have taught you about apoptosis in your college. And finally, the thing is, macrophage will come and eat the thing, right? Macrophage is an inflammatory cell, yes or no? Yes. So did they talk to you about apoptosis and did they tell that there'll be no inflammation in apoptosis? They must have, right? Why did you ask the question? Yes, kind of that, Pari. You should have asked the question, right? You only taught me apoptosis will not have inflammation, or you should have asked that at least to me, right? Think. Keep thinking. Keep asking questions. More you think, more you become better. If you stop thinking, you don't become better. The only reason why I hate entrance exams is it never lets any student think. Think whatever happens to you. Ask any questions. Once you ask a question, you'll either get an answer or you'll get one more question. You become better, right? At some point of time, definitely your college, they will say it's not required for undergraduate. There are only two reasons. One, it's really not required. Second, I don't know the answer. That's the reason I say that. Fine. Okay. So now here, the reason why I'm still saying I'm not having inflammation is efferocytosis is not phagocytosis. That's why I gave a different term, different meaning altogether, right? In efferocytosis, there is no cytokines involved. When there are no cytokines involved, I will not have signs of inflammation. So here macrophage comes, eats it very silently without causing inflammatory mediators inflammation. We'll learn about inflammatory mediators in the next class. Fine. There's no inflammation here. When there's no inflammation cytokines, I will not have signs of inflammation. There are no signs of inflammation. That's why I say there's no inflammation, and that's why it's painless also. It's painless, there's no inflammation, but yes, macrophage do play a part in case of an apoptosis, right? This is what happens. That's how apoptosis ends, right? Can we quickly run through this before going to the next segment? So we'll go to the first one. Okay. So this will read the physiological and pathological. Okay. Now I have two phases, initiator, execution. Two pathways in initiator, intrinsic and extrinsic. Both will join and form the same execution phase. Fine. Now, extrinsic pathway is cell membrane mediated. A normal cell will have its FAS receptor. That's normal. Let's assume the cell is infected with virus. The FAS receptor is still there. When I have a virus infected cell, the lymphocyte will come and try to protect me. The lymphocyte will have the ligand for the FAS receptor. I have a cell infected by the virus, lymphocyte comes, binds to the receptor. It gets activated. Once the receptor and ligand is activated, it will activate FADD, a downstream pathway that will activate an enzyme called as procaspase 8 or 10, which will be converted to active caspase 8 or 10. This can directly trigger the execution phase. Once extrinsic is there, I don't want intrinsic. Both does not happen in the same place, right? Then we had intrinsic or mitochondrial. I have a few proteins and genes which are regulating this entire pathway, right? They're all present on the outer mitochondrial membrane, the proteins, and they have some domain called as BH domain. Based on that, I classify them into anti-apoptotic if I have 4 domains, pro-apoptotic if I have 3 domains, And if they have only BH3 domain, I call it sensors of cell stress. Anything with L is anti. Anything backs and back is pro. Rest everything is sensors of cell stress, right? Again, let's go to normal mitochondria. A normal mitochondria of a cell which is normally living and doing its job will have BCL2. This will block cytochrome C going to the cytoplasm. So cytochrome C does the function of the ATP synthesis, electron transport chain functions normally, no problem at all, right? Now, when you have an insult like a DNA mutation, mutations will trigger sensors because they only sense the cell stress. Once they trigger that, BID-BAT Puma-Noxa will be activated. They will do two things. One, destroy BCL2. Second, activate backs and back. Once backs and back is activated, it's an ion channel. It will push many proteins from the mitochondria to the cytoplasm because all these are present in outer mitochondrial membrane, right? So once it's activating, cytochrome C comes outside, SMAC diablo comes outside. SMAC diablo will stop few proteins in the cytoplasm called as inhibitors of apoptosis. Their normal job is to inhibit apoptosis. They'll come here, destroy that. So makes the cell ready for apoptosis. Then cytochrome C will bind to one more protein called as APAF. APAF forms a group of structure called as an apoptosome. Apoptosome functions also is to activate caspase, procaspase 9 to active caspase 9, right? Now, so I had either intrinsic or extrinsic. Ultimately, I have caspase 8, 9 or 10 there. This will activate my execution phase. So once I have execution phase, this will activate either again few more caspases 3 or 6 or it will activate endonuclease. Caspase is nothing but a protease with cysteine in its active site and aspartic acid residue is where they'll cut the protein. Protease. Endonuclease is a restriction endonuclease. Just give me a second. It's a restriction endonuclease which will kind of restrict or cut at the restriction sites or your palindromic sites, right? I had a cell, caspase came, destroy the protein, the cell became smaller. That's how it will be, and it will become darker because precipitated. And endonuclease will destroy the nucleus, become smaller, darker. So this cell, once the entire ATP is destroyed, the flip happens because of the phospholipase, phosphoglyceride and your thrombose model that will break them into tiny bubbles, and these bubbles are called as apoptotic bodies. So the apoptotic body will be smaller, darker compared to the normal cell, may have your nucleus or may not have the nucleus because it's been destroyed. If it's destroyed in these two places, I might not have the nucleus. If it's destroyed like this or the bleb comes like this, I might have the nucleus, right? That's what an apoptotic body is, fine. So once the apoptotic body comes outside, they should be eaten by macrophages. And the signal for the macrophages comes with the same phosphatidylserine, same thrombospodin. If they are inside, the cell is living. They break and come outside. They flip outside. The cell is dead. Or an apoptotic cell, macrophage knows it and destroys it without releasing cytokines. That's why there's no inflammation here. Fine. No hit. Even if it's happening in a very long group of cells, it will not cause inflammation. Right? You like it, Suresh? Welcome. Snagit, if virus activates flip and they stop caspase formation, apoptosis cannot happen. That's when we trigger one more pathway called as necroptosis. When virus can think, my body also can think and go to necroptosis, right? So clear the entire pathway of apoptosis. No issues, no doubts. BH 1, 2, 3 means 1, 2 and 3. I should have written 1, 2 and 3, right? It's 1, 2, 3. 1, BH 1, 2, 3 or 3 domains. Fine, Darshan. BH 1, 2, 4 means 4 domains. Okay. That's a representation, Darshan. That's all. Okay. Now, this is a liver, right? This is structure of a liver. This is a hepatocyte. Okay. Compare this to this. Can I say the one with an arrow mark is smaller? I'll repeat that once again. Hit. Smaller. It's smaller. Can I say the cytoplasm is darker? It is darker. Can I say the tiny nucleus here, whatever I'm seeing here, that also is darker and smaller? That's an apoptotic body. Throughout the body, whatever organ it is, apoptotic body will look the same. Smaller than the original cell, darker cytoplasm, darker nucleus, with or without nuclear inclusion. That's how an apoptotic body looks like, right? Okay, that's how apoptotic body looks throughout the body, from head to foot. Same finding for necrosis 1 and for apoptosis 1. Fine. Now let's have a quick talk about Yes, both comes outside, right? Hence, why the blood forms, like I said, I have few proteins which is maintaining the integrity of the cell. Those are the phosphatidyls and thrombosmodel. They lose the function, so they just flip out. They very, let's imagine cell like a bubble, and some force from inside is just tearing the membrane apart very fast. So it kind of breaks down to small bubbles. Same soap bubble, it breaks down to small bubbles. Those are blebs. You or me, Shiga, if you can explain, that'll be great. If me, I'll try to draw it and I'll send it across if possible. Fine. Okay. Now I need a method to diagnose apoptosis, because unfortunately apoptosis cannot be picked up with blood test because nothing leaks outside, right? One method is obviously H&E. By H&E staining, you can, it's your test paper, do whatever you want. If the examiner understands, great. The examiner does not understand, very great. So you'll improve. That's all. Don't worry about it. You write anything, whatever is making you comfortable. It's a modified phospholipid. Yes, it has a phosphatidyl domain with the serine in the important point. Okay, Maria. It may be a glycoprotein or some kind of it. I don't know the exact biochemical nature of it. It should be some amount of lipid and protein, some modification of that. Fine. You should answer that more better than me. We are fresh from biochemistry, right? So here I can see the apoptotic body. That's one step. But I'm not going to take a biopsy of everything. Fine. Methods to identify apoptosis. Okay. Because I don't have a blood test like necrosis, troponins, or AST, ALT, right? Okay, Sachit. Fine. Next, I have something called as DNA agarose electrophoresis. You must have read about electrophoresis, protein electrophoresis in biochemistry. I can use that method also to detect your apoptosis. We'll see how to identify them very soon, right? And I have a method called as tunnel assay. Just remember this name, not needed to remember everything regarding tunnel, but I'll try to explain the basic principles here. Which of these two, necrosis or apoptosis, will have cut DNA? Which will have cut DNA? Which will have cut DNA? Apoptosis, right? So tunnel is, its TU is few of the enzymes. NEL stands for nick end labeling. Okay, that's what tunnel means. So this will stain the cut DNA or the cut end of DNA. So obviously apoptosis will have the cut ends of the DNA because I have fragmentation, and that will be stained by a method called as tunnel. That's a basic principle. You not remember anything beyond that, right? Now, can I tell phosphatidyl serine will be on the outer aspect only for every apoptotic body and will be on the inner aspect for every normal living cell? TU stands for terminal deoxynucleotidase transferase nick end labeling. That's why I didn't tell that. It's a big enzyme name. Fine. It's a chemical name. Yes, right? So I have a stain called an annexin. So annexin is a stain. This binds to phosphatidyl serine. I'm writing PS for phosphatidyl serine. So this will be positive only in an apoptotic body, because only in an apoptotic body this phosphatidyl serine will be on the outer aspect. For everything it will be on the inner aspect. Fine. So that's a method for us to pick up apoptosis. Remember that, right? This has come in an exam, so let's a little bit read in detail about it. Fine. Yes, Bhavana, like we discussed in necrosis, when I have a myocardial infarction, we use a blood test of troponin to say that myocardium is dead. That's a step because the intracellular contents come outside. Fine. Okay. Okay. So if you remember electrophoresis, can I say in electrophoresis the band moves based on the charge and the weight of the protein? Yes, to the cathode and anode and everything, right? So this is simple DNA electrophoresis, right? I have three things here, A, B, and C. Okay. If you look at this part versus this part, okay, which you think has fragmented DNA? The one in the center or one in the corner? Punit, you should ask medical Dr. Santosh for that. I am not coming into which is more sensitive for it. Let the cardiologist and internal medicine person take care of that. The middle one, right? The middle one is more fragmented because it's easily visible. So can I say the middle one is for apoptosis? Obviously, it's apoptotic, right? This was given a fancy term. It looks like a ladder, tiny fragments, right? So we call it an step ladder pattern of electrophoresis. Okay, it's a step ladder pattern of electrophoresis, which means it's apoptotic. That's all. It's a fancy term, right? So now here, if you look, can I say it's lysed DNA? Yes. Actually, it's simple, right? I have, these are all DNA electrophoresis. So in the center of it, if you look, I have tiny fragments, which means endonuclease is acted on it. Only endonuclease can cut it. So I have tiny fragments of DNA. Other place, I have a uniform thing, completely lysed DNA. So that this one is for your, it looks like a smear. You must have made a peripheral smear in your first year, right? There's a smearing pattern of electrophoresis seen in necrotic tissue. And this here is a single molecular weight of DNA. That's a normal cell. Because a normal cell will not have destroyed DNA or cut DNA. It's a single one, right? So I have a step ladder pattern and I have smearing pattern. These are primarily for MCQs, or if they ask you in Viva, you should be able to answer that. Fine. Okay. I think I am hiding that image. Is it visible now? The step ladder pattern? Yes. Lakshmi. You can have a step ladder pattern and you have a smear pattern. The B is for apoptosis, C is for necrosis, and A, where I have only one molecule of DNA, that's a normal cell, right? So these are different types of DNA electrophoresis. Again, a way to identify necrotic tissue. Fine. Perfect. Great. Okay, that's all for today. What I'm not going to discuss today is two things: necroptosis and pyroptosis, right? I have recorded lecture for that. I want you to just have a quick look at about necroptosis and pyroptosis. They're not there in the CBME curriculum, but I think it might help you if you read that, right? You take care of that. I will definitely cover that a little bit in the next lecture, or in the sometimes in the other lectures, but it's not there in your curriculum, so I don't know whether to teach you or not to teach you. Okay, these are done. See, it's a lysed DNA, right? So what happens is these are all experimental methods. I can't do it in real time. I kill the tissue in the lab, take the DNA outside, extract the DNA, and then I do electrophoresis. It's not done for real life, right? The major mechanism of atrophy by default will be ubiquitin proteasome pathway. Ferroptosis, it's a useless new thing, Neha. It's also there. None of them is there for any curriculum. I'll try to cover it, but I don't know whether it's important for you or not for you for university exam. No, Snehajit, same question like Kumar asked. If there's no DNA, I won't have anything, right? I won't have anything. So these are all experimental studies done during the process of cell death. I can extract the DNA and I can use it. If it's completely gone, I won't have anything by default. Okay, fine, great. Okay, so we're done with necrosis and apoptosis. Aber RRS it's close to me, right? My only thing is for me as a teacher, I want every student to read Robbins because I feel there's no replacement for Robbins. So whether you're not with me, be part of PW or not a PW, I'll make sure I'll try to simplify Robbins. So I want you to give a confidence of that. Nishchay Batch is where I'll be covering the topic faster because RRR time is a constraint. I'll go small, tiny topics which will take a very long time. That's the only difference, fine? Okay, Anurag, if it's from PW, please share the question with me. I'll try to change them. But again, it is also dependent on what the question is. If you can give me the entire question as the option, I'll be able to justify it better. Lakshman, Nishchay is more than enough. Bleb is not a scientific term. It's a bleb, that's all. I'll ask them to have a look at it, fine? Shushmita, it will be there in the Telegram group. If you ping me on Instagram, I'll put the link again in my story. Just have a look at that, fine? We look at it. Ishika, we'll look at the other things subsequently. And we are not done with the cell injury. We have lots of more things left in this chapter. We'll definitely cover that, fine? Thank you guys. See you tomorrow. Tomorrow not my day. Tomorrow I think is pharmacology. I'll torture you again the latter of this week. Fine. Bye. Good night. Sure, Anuradha, we'll definitely start for it. I'm sure your exams on December will definitely start it. Daily 2-3 pages should be more than enough, Ayan. Abir, I will leave it to you, whatever is comfortable for you. Tanvi, again, ping me for that furry notebook. I'll try to expedite it. Fine. Thank you, Shijat. Thank you, guys. Thank you for your time.